Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. A warm welcome to Season 3, and I hope you've all had a wonderful start to the new year. Let's get right into it. In this episode, I'm delighted to talk to Professor Richard Matzopoulos. He works in the Public Health Department at UCT and is also the Director of the Burden of Disease Research Unit at the South African Medical Research Council. He is probably the most recognized expert in the country in terms of harm reduction research when it comes to alcohol misuse. In this episode, we are chatting about the cost of alcohol to our healthcare system and the population of South Africa at large, highlighting the measures that can be taken to reduce harm to the people and reduce the burden on our already straining healthcare facilities. We discuss what influences policy in both positive and negative ways. We discuss the natural experiment that was COVID lockdowns, and we discuss the ongoing work that he and others are doing, focusing on harm reduction strategies. Without further ado, welcome Richard. Would you mind starting us off by introducing yourself and giving us a brief background into your professional career so far?
Yeah, sure. So Richard Matzopoulos. I've got two handles. One is at the South African Medical Research Council. I'm director of the Burden of Disease Research Unit. And part of my time, about 2 days a week, is spent at UCT in the Division of Public Health Medicine. It's been an interesting career because I'm not a medic. I started off doing business science, quantitative research, information systems, statistics. And through that was a pathway into public health. So then a master's in epidemiology, and after that, a PhD in public health a few years ago.
As the director of the Burden of Disease Research Unit, what do you do on a day-to-day basis? And then could you also touch on the work of the South African Medical Research Council in general?
I don't do anything consistently on a day-to-day basis. So I think it's the variety is the main thing. I mean, my background is in this field is mainly as an injury epidemiologist. But as a unit director, it's all diseases, it's all health outcomes. And what we try and do is provide health information that's useful for policymakers, for resource allocation and planning across all diseases, across all risk factors. And so I'm constantly being drawn into subject areas that I'm not particularly expert at, but I guess the art of the science is knowing who to call, when, for which problem, and I work with a multidisciplinary team, so it's always groups of experts in particular subsets that I work with, which makes it very interesting because I don't think I have a routine day-to-day job or thing that I do every day. So there's several cross-cutting units that are maintained by the MRC. Burden of Disease Research Unit is one of them. There's also a biostatistics unit that lend their substantial skills to a variety of projects and collaborations. There's the Cochrane Center that specializes in systematic reviews, health systems. So some of these cross-cutting units, they all have different mandates, but they support research across the organization. But then there are also specialized units that look at disease types. So there's a mental health and substance abuse research unit. There's an NCD research unit. So several major several major diseases or outcomes have units in their own rights, and then there are these cross-cutters that support a range of units. And part of what they do as well is also funding research at universities, at other research institutions, and health and innovation. So they're also looking at, there's a platform that specializes in uptake of technological solutions. So it's quite a broad suite of priorities that they assist with.
Awesome. So the main reason I asked you onto the podcast was because I heard you speak at a conference last year, the World Health Expo, where you were chatting about the research you've done and your team has done into the burden of disease of alcohol on South Africa. and you wrote a paper that was published in the SAMJ in 2022 that highlighted the fact that, or one of the stats that came out of that was that alcohol contributes about 7% to South Africa's burden of disease. And that has quite a wider spread of burden than one would initially think. One tends to always hear about road traffic accidents, but you tell us about that burden and tell us about the paper as well as the variants of the burden.
So that paper was part of a much broader study where we looked at the contribution of 17 major risk factors, the ones that drive the disease burden in South Africa, and alcohol was one of the leading risk factors. I think the single greatest contribution was from unsafe sex as the leading risk factor, which obviously drives the HIV burden. Alcohol, I forget the ranking, it was 2 or 3 perhaps, and 7 to 8% of the burden is a substantial amount. As you say, we always expect road traffic and injury-related causes, and there are probably reasons for that. Our thinking is shaped a lot by what is put out there by the media, by the alcohol industry, and also our perceptions, which tends to focus on the immediate effects of drinking. So you've also got to recognize, though, that drinking has long-term detrimental effects. And then there are other acute conditions where you don't necessarily note that they are drinking related. So to give you some examples of those, I think the injury ones are self-evident. You drink a lot, your behavior changes, you start engaging in risky behavior, and things happen, and we're able to easily calibrate if you hadn't been drinking what the risk curve would have looked like, and so we can apportion an amount of the risk to the drinking behavior. Another acute effect that we probably don't think about is the choices you make for unsafe sex when you've been drinking, and so the role of alcohol in driving the HIV burden is something else that we can start measuring and attributing a burden to. So that's an effect of acute drinking. The drinking also changes the way people would adhere to medication, and so the effects of not following your medication regimen would affect HIV and it would affect TB. So
amongst other things. The amount of epileptics we see coming through because they were drinking the night before.
Absolutely. So there are acute effects that we miss, and then there are a range of chronic conditions as well. Roughly, if you apportion that burden, you could say that about a third of it is injury-related, a third to infectious disease, and a third to chronic conditions, including cancers. There are 100+ conditions where you can measure the role of alcohol in driving some of the disease burden. The quality of information that we have is not sufficient to actually measure all of those in South Africa, but we at least are able to estimate the contribution to some of the major causes.
So on the other side, you mentioned the road traffic and the immediate causes are what we think of often from our perception in the media and the alcohol industry. So the alcohol industry is obviously driving production and consumption of alcohol naturally because they're selling it. According to a report that was commissioned by the Drinks Federation of South Africa in 2024, the alcohol industry contributes about 3.6% of our GDP, or about 226 billion rand, and about 500,000 jobs. So if you can have a guess in terms of tangible cost to our healthcare system, as well as intangible costs to loss of work, loss of productivity, social ills that are born out of alcohol misuse, can you put a figure to contrast that thing?
Absolutely. We've done this before. So the easiest way to do this, and the biggest contribution is in the burden, premature mortality, and years lived with a disability arising from drinking behaviors, you can start quantifying. You've got that metric to begin with, and you consider the value of a statistical life. What is your life worth as a South African? And simply multiplying those two gives you the major contribution to the burden of the financial burden of alcohol to the economy. So we did that exercise around 2014, if I remember correctly, the publication date. And I think the estimate was about 10% of GDP from drinking, which vastly outweighs any economic contribution of the industry to South African livelihoods. Although I haven't looked at the Drinks Federation report, and I'd be surprised if they hadn't exaggerated some of those metrics as well. I mean, you've got to take industry reports with a pinch of salt. They would be exaggerating the contribution to the economy. I mean, 500,000 jobs is a phenomenal number. So it's 1% of South Africans, but in terms of the adult population, the working population, it's a few percentage, which really doesn't make much sense.
Yeah. And the splits between, so from that report in 2014, did you split between the tangible and the intangible costs? Like how much is it directly costing our healthcare system? No, that would probably be old data, but.
So the tangible costs are about 1.6% of GDP. So those are direct financial costs that are paid by government, whether it's to avoid crime, to respond in terms of addressing health needs of individuals and so on, and social services. The intangible costs are approximately 10% of GDP. So it's interesting if you use the industry figures at face value and the financial costs, they would be saying to you that they contribute double to what the alcohol industry takes away in terms of financial costs, on the proviso that you don't value a life. And that's a massive assumption from a healthcare perspective, or even a human perspective, that your life is valueless.
That's the whole point of healthcare.
Absolutely. Yeah. So it only works with a massive assumption. And I mean, I guess that's the thing with disease and disease burden. I mean, somebody's got to bear that cost and discomfort. And the way you create a financial case for an industrial epidemic is by ignoring that. So if we can not value human lives and suffering and so on, then you can make a financial case for practically any product.
More recently, with the COVID lockdown regulations, we saw a glimpse of what hospitals would be like without alcohol, without the burden of alcohol use. Could you touch on that period and the insights that you gained from that?
Yeah, I mean, it was a critical moment and natural experiment, essentially, withdrawing alcohol to a large extent, formal alcohol production and distribution from South African society, some of it unforeseen and unexpected. So we're particularly interested in one of these complete bans, which was unannounced and, announced on Sunday night, and then on Monday morning, the taps had been closed. And so that was kind of a perfect natural experiment. And we measured that and pulled apart every other possible confounder, the effects of mobility restrictions, et cetera, and concluded that, hundreds of lives per day were saved as a result of this alcohol ban being imposed at short notice. And the classic anecdote is Baragwanath Hospital on New Year's Day during the alcohol ban over December, where there was not a single case in the trauma unit on New Year's morning, which is unheard of. I mean, it's normally swimming in blood and bodies, but also the smell of alcohol. And I think if you speak to any trauma surgeon or anybody working in the trauma unit, the overwhelming impact, busy trauma unit on a peak time on a weekend, is the smell of blood and alcohol. And so it's a major driver of particularly on weekends.
I can remember I was at Mitchell's Plain during the lockdown, and it was in those first initial regulations, when we weren't actually seeing very many COVID cases yet.
Yeah.
And then the alcohol ban came in, and then we had nothing to do. And everyone was clapping for us.
You've done such a good job. Yeah.
And it was bliss because there was no trauma in the unit. Yeah.
It was a critical moment, really. And you don't expect that it's something that you could replicate without COVID, having a complete alcohol ban. And I don't think anyone's advocating for that. It's an extreme measure. But just to demonstrate the impact of alcohol so obviously for everyone in society, in a trauma unit, but also people living in the environment where alcohol is not regulated. I mean, the overwhelming response from people living in afflicted communities was how much safer it was and how much quieter it was. So you don't have drinking and carrying on late at night. You could actually get a proper night's sleep. It just, makes South Africa so much safer by withdrawing it. So you don't expect that an alcohol ban or prohibition is something that would be enduring or revisited without COVID, but certainly there are a range of policies that we should be exploring. We've had this incredible experience, demonstrable decline in alcohol harm, yet we haven't really moved ahead with evidence-based strategies to reduce harm. And we should be cranking up excise taxes, minimum unit pricing so you can't buy cheap alcohol, regulating hours and days of trade better, removing advertising. There are a whole range of strategies that are known to reduce harm. But, that was a policy window that we should have been jumping through, and we've kind of ignored it, which is really sad.
And in terms of a lot of these strategies that you have mentioned, a lot of them have been applied in other countries, particularly in the global north. Would you say that this is a lot of people have speculated, but there probably is some evidence that the alcohol industry, in a similar way to the tobacco industry, has retargeted its advertising more on less regulated countries?
Yeah, absolutely. I think there's growing evidence that they're trying to tap new markets and new market segments. So Africa's definitely seen as a geographic area of growth. Drinking has been part of many African cultures, but typically it's informal or at a micro level. And so there's a tremendous opportunity for marketing and mass production of industrial alcohol at scale. So, and I think you can see this across Africa, poorly regulated, untapped markets. In South Africa, where we have such tremendous heavy episodic or binge drinking, it's limited to a relatively small segment of the population, which is predominantly male, very few women, and you can see the industry's response there, trying to increase the share of women drinkers very successfully as well. You can actually see that in the data. While there's decreased drinking in older age groups, you can see an uptick in the percentage of drinkers amongst younger women and an increase in the amount that they drink.
And in terms of demographical data, a lot of the world, the younger populations, the 18 to 25, 26-year-olds are drinking far less than 10 years ago, 20 years ago. Is that followed in South Africa, or do we not?
No, not at all. I think that's one of the reasons they're moving away from those jurisdictions where we're into places where there's still potential for growth and there's limited regulation.
Yeah.
And the effects of regulation are pushing up the price, reducing access, promoting and marketing alcohol. So you move to a fully regulated environment where you don't have any of those restraints and barriers. And you've got an impressionable population that's in some parts of Africa, increasing economic opportunities, becoming more urbanized as well. It's a fantastic growth opportunity for the industry.
And in terms of regulation, there's the Liquor Amendment Act that's currently, as far as I know, it's waiting to be addressed by Parliament. that is trying to regulate the advertising and on any platform of alcohol. What do you think is, I mean, I know there've been acts like this in the past that haven't passed through. What are your thoughts on that?
There are a range of installed acts at provincial and national levels that the industry will do their very best to ensure stay in the wings that aren't actually ever promulgated or turned into regulations. So anything that is strongly evidence-based and that's going to make a difference to alcohol sales and consumption at a population level is something they're going to oppose using every mechanism available. Because I think you can look at the data, and essentially a lot of their profit is driven by the harmful drinking pattern. In fact, most of it. And if people drank less and we were able to regulate how much people drink and reduce it, it would have a tremendous effect on profit. And they don't have a mandate from their shareholders to reduce that profit, so they're going to do everything they possibly can to try and install regulations that will promote public health.
And then in terms of evidence-based policy guidance and regulation guidance, like the measures that you've mentioned, tell us about the Chase SA project.
Yeah. Chase SA is a new project. We've spent a year doing a lot of the administrative paperwork, setting up the contracting, the networks, ethics, and doing primary data collection. The interesting part is going to happen across the next 4 years, essentially, where we try and make sense of some of the data that we've collected and workshop some of the products in collaboration with the communities where we're working. So essentially what we're trying to do is understand everything about the alcohol economy, how people purchase their alcohol, how they perceive it, their behaviors, how the industry works in communities, how the industry interacts with government, how legislation is formed, how it's influenced, basically every aspect of how alcohol functions in South African society, but in Southern African society, because we also have sites in Botswana, but through the lens of communities that are particularly vulnerable and affected by alcohol.
And then use that information to, after all of that, after you've understood everything, then the idea is obviously to try and guide policy with that information.
It's the idea is to empower communities to use that information. So having a dialogue with those communities to influence policy and giving them agency to use that information to influence policy is probably one of the more important implicit aims of that work.
And from a community level, that would be from the ground up, community forums, WhatsApp groups, things like that, just to try and guide the natural behavior that South African communities have with alcohol.
I guess so. I mean, that's going to take shape over the next 2 or 3 years, exactly how we will beneficiate that information for use. I mean, the essence really is that we've done so much. We've provided so much evidence. I think it's irrefutable, the effects of alcohol, how much it costs the economy, how many lives are lost, what the evidence-based strategies are. All of that information has gone into policy, into the policy process, but it hasn't actually affected things. At the same time, there are communities that bear the brunt of it. You don't have the benefit of having that information at their fingertips. So the idea is to provide them with all the science backing to package the information in a way that they can use. How they end up using it, we are open to what you've suggested, but also what might come from the community. So that's part of the co-creation process over the next 2 or 3 years. And then I guess we wrap it up and see what we found and try and carve a way forward.
And then from an international perspective or a regional perspective, you mentioned obviously the Chase SA is working with Botswana too, but with international trade and international regulatory bodies like I'm not sure how much they would be involved, but like the World Trade Organization, the African Union, things like that. How much of a role do they have in terms of imposing their influence on a more national orientated policy? So like if the World Trade Organization realizes that this is a huge threat and problem facing Africa, we need to really help regulate huge international alcohol companies to tone it down. How much power would they have over a situation like that?
Look, I think they must already know the effects of alcohol and injuries. I'm sure they understand what tobacco does. So I think they have an important convening role. They have an important normative role in setting what the guidelines are and what works and so on. The actual influence, I think it really depends on the interest of the member states to actually respond to that guidance. So I think they can influence policies, but I don't think they can assist with enforcement, and that's really going to come down to each country. South Africa's really a really important piece of that cascade as well, because I think a lot of even though we lament the stalled draft National Liquor Act and some of the other legislation, the fact is that some of the regulations and policy in South Africa is further developed than other parts of Africa. As much as we are interested in bolstering it, I think the industry is probably also very focused on undermining it to ensure that, good public health policy doesn't gain a foothold in the South of Africa, because there's a domino effect, and other countries are going to be influenced by those good public health decisions.
And then just a thought I had, what might be a good idea. I know the data, like you say, is pretty irrefutable as we stand at the moment. But do you think from an ethical perspective, this is just a late night thought I had in the emergency unit, do you think it would be ethical to add a breathalyzer as part of your triage score and just say, look, we're not going to arrest you. We just want to know if you've been drinking. Like for everybody, just to get like currently 80% of our unit is drunk.
Yeah. Well, I mean, you know that already. So do you need to be collecting that information objectively? We've done a bit of work on this in response to what happened during COVID. I think the health department was suddenly in the spotlight, having to support government's decision with the alcohol ban, and wanted some hard numbers. It's very difficult because we don't really have a proper injury surveillance system. So difficult to actually do a head count of how many trauma cases you have in the first place, let alone how many of them are under the influence. So there are pieces of information. You can look at the fatalities from places where there's an injury mortality surveillance up and running. And there are a bunch of research studies and your own experience working in a trauma unit. And any doctor that's worked in a trauma unit will be able to tell you exactly what you've said. It's 70, 80 or 90% of our trauma cases, depending on which day of the week, is under the influence. But there isn't objective information coming through. And so there was a lot of interest in trying to respond to that. And we ran this pilot study in response. The idea was to use a rapid finger prick test initially and test it against bloods and other instruments. The MRC funded it as a flagship project. We did a lot of work with trauma surgeons and people working in the health service about the feasibility. And some of the interesting things were, firstly, the finger prick test didn't work because of alcohol swabs, obviously. Everything has alcohol on it nowadays, particularly during COVID. The instrument itself, the diagnostic test didn't seem to work in our settings despite that. There was a real problem calibrating it. But what we did instead, we substituted in a breathalyzer, not a calibrated breathalyzer, which we also test, but a passive breathalyzer. And basically just testing without the person actively blowing, but just hovering that breathalyzer above their nose and mouth. And we were able to reliably test alcohol. I think if you look at bloods or the active breathalyzer, using the passive mode, we captured 210 out of the 219 positive cases. So very, very accurate to give you just whether there's alcohol present or not as a screening. The question then you asked is about ethics, so we could get this past ethics for a research study, but in discussing that with the clinical staff, the question is, how is it best integrated? As we'd have to make sure it doesn't disrupt any type of patient treatment. What is the additional burden in terms of collecting that information? So I don't think it's an ethical issue. I think from a purely the data collection aspect, as long as we're not provided it's not being used for evidence and potentially at the expense of the patient, as long as it's not interfering with operations in the facility, I don't think there are major ethical issues that can't be overcome. It's more of a logistical issue, and how do you integrate this, and what are you integrating it into? There isn't an existing trauma surveillance system. So I think, first thing is to try and develop either a Sentinel-based or a routine system to collect injury information that would influence policy, including a very light touch alcohol diagnostic as part of it. It makes perfect sense to me. And I think the first thing is trying to set up injury surveillance there.
I think just personally and anecdotally, I think it would be useful for a clinician if you had it as part of your triage, like this is your blood pressure, that's your pulse. You hear with like I said earlier, you hear with the epileptic fit, and the breathalyzer beeped positive. That gives us a added piece of information. Or you hear with a bruise on your head and you're a bit drowsy, you definitely have alcohol in your system. Let's watch you for a bit.
Where it becomes very useful is if you start integrating things like brief motivational interviewing or problem-solving therapy into part of the routine treatment. So in knowing exactly who should be the beneficiaries of that type of intervention would be helpful. And Catherine Sorsdahl did some work a few years ago in Kailicha, and the fascinating thing for me is, that idea of a teachable moment with brief motivational interviewing. The results were impactful for BMI, problem-solving therapy even more so, and I think that involved a lay counselor. But the fascinating thing for me is that the screening questions themselves, which were applied to the cases and controls, were effective. So just asking people a couple of questions about drinking behavior, either the screening questions seem to have an effect in their own right.
Makes you stop and think.
Yeah, exactly. Why isn't that integrated?
Yeah. That could be integrated in and of itself, just asking people questions and they don't have to even write down the answer. It might prove beneficial. And then in terms of preventative medicine in general and research around drivers of health, there's obviously a huge burden that we're facing in the healthcare system, in hospitals and primary, secondary and tertiary care facilities. On a government level, everybody's overburdened, overstretched. There's a lot to do. There's a wave after wave of people arriving. Mm-hmm. There seems to be a time from a clinical perspective to step back and look at the bigger picture. Mm. And from a public health perspective, that is what you do. Mm. You look at the bigger picture, you collect data, you try and address the drivers of health. Where should those two worlds meet, and should there be more communication between the two?
I don't think it's an absence of knowing what the risks are or the upstream determinants, and I think the health professionals get it very easily, and you can understand that your day-to-day job is putting out the fires, but you've got a good sense of where they're coming from, and I don't think there's too much convincing is needed. It's really around the political will to change things. And I think there's a lot of synergy between clinicians and public health people around root causes and what might need to happen. But it's trying to convince other stakeholders. And I think there's silos in government and competing agendas. It's very difficult to push some of the upstream thinking that would actually make a fundamental difference. So we've been speaking at length about alcohol as one of them, but there are they're a group of government departments who only see the economic development aspects, or see alcohol as a source of sponsorship for sports and recreation. So trying to put the social issues higher on the political agenda, I think, is the challenge that we need to address. That's very difficult because with commercial determinants, they're commercial actors that benefit from the the downside that we're picking up in the health facility. It's not just alcohol, it's tobacco, it's firearms, it's automobiles as well. I mean, they're much more efficient transport systems than private car ownership. There are a range of these competing commercial determinants that drive the health burden. Difficult to land that message, though. And another deflection is often talking about drugs instead of alcohol, particularly if you're looking at organized crime and gangs on the Cape Flats. It's not an area that I'm particularly familiar with in detail, unlike alcohol, where I've worked extensively. But drugs are not well served by treating them with a criminal justice handler. Drug use and alcohol use is more of a mental health issue, and treating drug addiction, recreational drug use as a mental health issue, I think, is a much more humanistic approach, and one that's probably going to yield much better outcomes than dealing with drugs from a purely criminal justice perspective. So I think trying to review drug policy, how drug use is treated, punished, etc., is something that needs to be reworked. It's really a moral panic issue, but essentially it should be a mental health issue. And I think that's where we've continued to be let down by local and international policy, essentially.
And I think just on that, I think also where I work, we serve Polesmore as our men. They all come to us if they need help to be in hospital. And I think that's a pretty radical example, but our punitive system for drug-related misuse and sale and crime that is born of it. Obviously, there's a lot of violence born of it, which complicates things. But the punitive justice system that we have in terms of drug use makes the problem worse.
Absolutely.
It actually is not helping the person. It's not helping the industry. It is making the sale, the use, and the complications of it. It is driving all of those up.
Absolutely. I mean, on the one hand, you're criminalizing the user who is using due to the hardships they're facing, the mental health challenges they're facing. You're criminalizing that person who is vulnerable and mixing them with potentially violent criminals. On the other hand, you've got violent criminals who you are providing with you suggesting an income stream, a lucrative income stream to them that is linked in with habituation of mental health problems, so logically, it really just doesn't make sense, And so you're incentivizing the trade in this really harmful product by suggesting that the most ruthless, violent actors that can corner the trade, which is very risky because of all these punitive measures, which in turn only escalates the price. You're creating a financial incentive for the violentization of a mental health issue. It defies any kind of logic, and we don't question it, and it's this kind of self-perpetuating cycle of harm.
Last question. If you had a magic wand and could wave it and something would materialize overnight in South Africa, what would that be?
Well, the fact that you've made it about South Africa is what qualifies my answer, because I think a lot of these questions and challenges apply to many different settings. That you've got the same commercial actors, you've got some of the same risks. We've got some massive ones here with inequality, which I think that's a South African specific driver. There are few. When you're confronted with an injury topic, people often want to know why did this happen? What's the special South African thing that makes it so bad? Well, the one thing is inequality. The other one is our attitude and our propensity towards violence and using violence as a show of strength and way to resolve conflict. Many of the other risk factors are universal, essentially. It's just to what degree do we have them? So I guess my risk for South Africa is to possibly and other belligerent type countries is to stop seeing essentially shows of force or violence are not a strength. There is a weakness and something to be ashamed of. And so changing the mindset is the one thing I would like to do with my magic wand. And then obviously, addressing inequality and giving people access to opportunity and means is something that I think would impact violence and injury, but a whole range of health outcomes.
Good answer. Well, that's all. So thank you so much for joining us, and thanks for taking the time today. I really found that conversation interesting, and I hope our listeners did too.
Welcome. Thanks so much, Dan. Cheers.
That's all for this episode. To recap, we spoke about the work of the South African Medical Research Council in general. We also highlighted previous research on the cost of alcohol in terms of both tangible cost to the budget and also the intangible cost when looking at the societal effects of alcohol and metrics like disease-adjusted life years. We spoke about the financial incentives of the alcohol industry and the influence that has over our government. And then we spoke about the ongoing projects such as Chase SA that are trying to understand how to make communities safer and reduce harm in general. Be sure to rate, review, and subscribe on all of your favorite platforms, and share the podcast with a friend or colleague who might be interested. If you'd like to get in touch, find me on LinkedIn or email me at dan@badem.co.za. Follow us on Instagram and Facebook at Brave African Discussions and on X or Blue Sky as BadEM. See you next month. Bye bye.